I'm Dr. Ben from Hospital Sungai Buloh. So I'll take you through a quick presentation. So this is actually meant mainly for people who are new to COVID or have left COVID a long time ago and now coming back to join the group. Yeah, and it's targeted towards hospital doctors working in the hospitals. All right. So I wanted to start off just talking about incubation periods, and this is something we know much better now compared to when we first started off. So it looks like incubation period is very clear. It peaks at 5 days. So if today I'm exposed to somebody who is COVID positive, today being Monday, so by Friday or Saturday, that's when my symptoms will start. Okay, now it can start as early even as Wednesday. Okay, that means 2 days from now it can already start. Okay, or day three lah, day three after today, day 1, day 2, day 3. So anything from Wednesday onwards, it can actually start already. So most people get their symptoms up till 7 days. Okay, they get it up to 7 days. Okay, so between today and Sunday, most people would have gotten their symptoms. All right, by 14 days, more than 97% of people, if they were to kena COVID, they already kena COVID lah. Okay, in fact, I think they say it's 12.5 days, like 12.5 days, more, sorry, 11.5 days. 11.5 days, 97.5% of people already kena symptoms lah. Okay, that's why we put the incubation period as 2 weeks. In other words, that once 2 weeks has come and you haven't got symptoms, chances are extremely high you didn't kena COVID lah. Okay, yeah. Now, what we do know next also is that there's this one almost everybody knows the main mode of transmission is by droplets. Okay, and so when do droplets happen? Droplets happen when you talk, when you cough, when you sneeze, when you sing. That's when respiratory droplets come out, and respiratory droplets don't spread more than 1 to 2 meters away from that person. So that's the main way in which it spreads. Okay, yeah, COVID spreads. Now, what about the role of formites or the role of surfaces when the surfaces get contaminated with the virus? It depends on how much virus there is on the surface, and it depends on how long it has been there on the surface and what kind of surface are we speaking about, and when your hand wipes on it and then wipes your eyes or wipes your nose, there's a theoretical risk of COVID spreading that way, but it is not the main way of spreading. The main way of spreading we know is by droplet spread. Okay, and there's also a lot of talk, a lot of noise also about aerosol spread. Aerosol spread, and do I have a slide on that? No, I don't have a slide on that. But there have been some nice studies that have shown that in a poorly ventilated area, so if you are in a closed up area, where like the two examples that came out was in a restaurant with an aircon and in a bus, in a closed up bus, and for those people when they were kept in a long time together, together with somebody who was infected, and there was no ventilation and there was no change of new air, then people could get infected that way. So when there's people are sitting close together and there's poor ventilation, then airborne spread does happen, but it is not common. Okay. The other thing that we do know about transmission as well is there was a recent study also that showed in Hong Kong, there was a patient who was COVID positive, and he was in the middle of the cubicle, and there were other patients around him. At the time, they didn't know he was COVID positive, and doctors and nurses, some wore surgical masks, some wore N95, and for the patients surrounding, some were wearing surgical masks, and but not all the time. And what they did show was that even though this patient was confirmed COVID, had low CT values, that means a high viral load of COVID, but as long as people were wearing masks around him, whether it was N95 or surgical mask, they were not infected. So the other patients surrounding him were not infected, people in the ward, in the cubicle were not infected, and the healthcare workers were not infected, but they were all wearing masks. Okay. Okay, so this is our own local Malaysian characterization of categories. So we come up with 5 categories of for COVID. First is asymptomatic. Second is generally a URTI. You know, you got respiratory symptoms or some other symptoms, but you don't have a pneumonia when I do a chest X-ray or CT scan. You know, category 3 is when there is a pneumonia, and category 4 means you need oxygen already, and category 5 means you need to be in ICU, or you've got organs failing, or you need to be intubated lah. Okay, so 1, 2, 3 we consider as mild, 4 and 5 we consider as severe. And if you look, this is our own Malaysian data. This was based on close to 6,000 patients who had COVID between the months of February till June, and the vast majority, 5,400 of them, had mild disease, either category 1, 2, or 3, and there were a few that came in. A few of them came in as category 4 and 5, so they came in as SARIs. They came in as severe. They started off with severe symptoms already, and those who had mild symptoms, most of them didn't progress to get severe symptoms, but some of them did. As you can see, 30 of them from category 1, 84 from category 2, 84 from category 3 went on to get. So in all, 8% of them eventually got severe disease. All right. As we know, one of the main factors of who gets severe disease is age. Okay, those who's so the moment you've crossed 50 or more, so if you cross 60, then suddenly the chances of you having severe disease and eventually death becomes higher and higher. Okay, so some of the challenges that we face in the wards, okay, when working in the hospital, number 1 is to make sure that there are no COVID patients outside. How do we ensure that there's no COVID patients outside of the COVID wards, okay, in the other wards, whether it's in the surgical ward, in the gynae ward, in the medical wards, okay? And then the second challenge is to identify those in category 1 to 3 who might deteriorate. Okay, and we will show you some of the risk, some of the warning signs for these people who deteriorate. Okay, and one of the biggest challenges is ensuring no healthcare worker ends up getting COVID, whether by taking care of COVID patients, or when they are not taking care of COVID patients, they are resting or they are working in some other ward. Okay, how do we prevent them from getting COVID? From what I'm told, that there are some healthcare workers in Sabah currently who have just recently been diagnosed with COVID as well. Okay, and one of the fourth priorities is how do we make best use of the PPEs that we have, the personal protective equipment that we have. So in order to ensure that there are no COVID patients outside of the COVID ward, we are suggesting for especially in areas where there's a lot of community spread. Currently, mainly in East Sabah, but actually even probably throughout the whole of Sabah and Kedah, there's significant community spread, and hopefully that scenario doesn't happen to the whole of Malaysia. Okay, so how do we identify patients who may have COVID? So the main thing is a low threshold, having a low threshold, a high index of suspicion for people having COVID in the hospital. All right. When it comes to, so people from epidemiological risk, people with who comes from red zones, no brainer, whether or not they are symptomatic or asymptomatic, just test them. Okay. Otherwise, people from who never traveled to a red zone, or people who are not close contacts with not close contacts to confirm cases, okay, or didn't attend any event where there was known COVID spread, then we go by symptoms. All right. So the symptoms can be a respiratory symptom, cough, shortness of breath. It can be a viral symptom, which is fatigue, body aches, headaches. Okay. COVID highlighted this symptom of anosmia, loss of taste and loss of smell, aguisis and anosmia. Okay. And some of them actually get a diarrheal disease as well. All right. And so they can get respiratory symptoms, they can get a viral-like disease, they can have anosmia, okay, or they can get GI symptoms. So apparently in the elderly patients, patients who are elderly, fever, lethargy, and diarrhea become much more prominent. So they may not actually have respiratory symptoms, whereas younger patients are more likely to have respiratory symptoms. Yeah. One slide just to tell you about the testing and why there are different tests for COVID. So this is time, the days since being admitted. All right, and this is what increases lah. Okay, so you got 3 lines here. You got the blue line, which actually tells you how much virus there is in the body, and then it shows you the IgM levels and the IgG levels. As you all know, IgG occurs later than IgM. So as I told you, most patients' symptoms start after day 5. Okay, so before day 5, you already you are in the asymptomatic stage or the pre-symptomatic stage. Even before you have symptoms, your virus is already starting to increase. And these patients, at least 2 days before the symptoms start, they are already infectious. Okay, they are already infectious. The main time they are infectious is actually between 2 days before and 2 days after the onset of symptoms. That's when the patient is most infective lah. Okay, yeah. So so the viral load increases, okay, and the antigens all increase, and then the antibodies start kicking in about day 7. Once the antibodies start kicking in, that's when your antigens start falling lah. Okay, yeah. So if you do a PCR test, the PCR test will pick up all of this. Okay, a PCR test will pick up all of this. But the antigen test, the rapid antigen test, tends to pick up only when the viral loads are very high. Okay, only when the viral loads are very high. Okay, and the antibodies, of course, most times antibodies will only start being positive 2 weeks after the getting infected by COVID. Okay, yeah. So the next challenge is identifying people in categories 1 to 3. Those with mild disease, who is it that actually deteriorates? Okay, so we have learned this from dengue. So we find out those who are at risk factors. Okay, who are those who are at risk factors of deteriorating? When do they deteriorate? And what are the warning signs that they show that they are deteriorating? Okay. There's one picture here about morning Passovers. What happens is that in our wards every morning there's a Passover from the so the doctors in Sungai Buloh work in 12-hour shifts. So this is the 12-hour shift Passover from the night doctors will pass over to the morning doctors, each and every patient. And during the morning Passover, we actually talk about what day of illness they are, the day of admission they are, whether they are confirmed cases or whether they are, PUI patients, okay, their age and the category of illness, okay, and then what test needs to be done and all that. So this is our very busy Passover ward. Later we were smarter and we pass over through through Google Sheets lah, okay. But we are still using these wards when the number of patients are less lah. All right. Okay, so so this is what the doctors are supposed to do. So this is for category 1 and 2. This is for category 3. This is for category 4. This is for category 5 patients. So for category 1 and 2, it's a twice daily review, once by the morning team, once by the night team. Okay, and the specialist or the senior MO does a board round. Okay, the board round is what I showed you just now. Okay, at the AM shift and the night shift, to make sure that if there's any patient that's not looking good, then they are brought to the attention of the specialist or the senior MOs. Okay, yeah. Most patients at the first 5 days of their symptoms, they are mild. They have not deteriorated yet. Okay, so most times patients start deteriorating after day 5, between day 5 to day 10 of their symptoms. Okay, so I repeat again. So if today Monday I'm exposed to COVID, most times by Friday I will start getting my symptoms. But my symptoms in the first 5 days of my symptoms, I will be mild. My symptoms wouldn't be bad. I wouldn't get shortness of breath yet. Okay, so that means on Friday I'll be fine, Saturday I'll be fine, Sunday I'll be fine, Monday I'll be fine. Tuesday I might start getting shortness of breath. Okay, Tuesday, Wednesday, Thursday, like that. Okay, I may start getting shortness of breath. Okay, so 5 days on average incubation period, and then 5 days before you start getting severe symptoms. All right, yeah. So so those with pneumonia, that means the chest X-ray has got changes, but the patient doesn't need oxygen. So also a twice daily review by medical officers with consultation with specialists or consultants. We calculate this mu score. Mu score is basically all your vital charts, like your blood pressure, heart rate, respiratory rate, consciousness levels, and all that. That contributes to your mu score. Okay, if the mu score is increasing, heart rate is increasing, respiratory rate is increasing, fevers is increasing, usually these are the warning signs that the patient may be getting more severe. All right. Then you've got patients who have got hypoxic. Okay, once patients start getting hypoxic, as in needing oxygen, they are complaining that they are short of breath, or the SpO2 is low, or the respiratory rate has gone up, then we need to review them actually 6 hourly. Every 6 hours we need to review, and a specialist to alternate with the MO to review a patient. Okay, we calculate the mu scores accurately, and if they increase again, we inform specialists. So this category of patients are already severe patients, and they need to be treated with a lot of care. Okay, and critically ill patients don't need to say lah. They are already in ICU, so they'll be reviewed as per when needed lah. Okay, so emerging symptoms are fever, cough, shortness of persistent cough, shortness of breath. These patients tend to be these are the warning signs that the patient may go on from category 1 or 2 or 3 towards 4 and 5.
Temporary or forever?
So this is what I was mentioning earlier. Who is at risk of getting severe disease? Age more than 50, but the higher the age, the higher the risk. Chronic kidney disease stood out, okay? And then you've got other medical conditions, high blood pressure, cardiovascular disease, if you're obese, if you've got underlying COAD, you know, if you're diabetics. So these are the main risk factors that were shown from our Malaysian cohort. But in multivariate analysis, those that really stood out was these two, age and chronic kidney disease. Most of the time, I told you they deteriorate about between day 5 to day 10. Okay, if they cross day 10 and they don't have any shortness of breath, almost always these patients do not deteriorate. Okay, I repeat. Once they have crossed day 10 of symptoms, their symptoms definitely started 10 days ago. They had sore throat and runny nose. And then after that, by day 10, no shortness of breath and all that, these are probably the 80% of patients who haven't developed severe disease. Okay, yeah. So you can probably, even if they are 65 years old, you can probably relax your monitoring on them. Okay, so how do we know that they are deteriorating? We go by clinical signs, we go by laboratory values, and we go by radiological signs. Okay, so clinical, as I mentioned earlier, fever doesn't come down or never had fever, now developing fever. Okay, lethargy, earlier was feeling better at day 5, day 6, then you start feeling very lethargic. These patients are probably going into the severe disease. Okay, anorexia, can't eat anymore now, or their cough is persistent. Okay, all these three lah. Every patient that we see in category 1, 2, 3, we ask this: do you get breathless when you walk to the toilet? We count your respiratory rate for 1 minute and see whether it is tachypnic or not, and we check your SpO2 whether it has fallen. Okay, any of these three suggests that you are going into category 4. Okay, we know that the CRP value is very important. We monitor the CRP. We don't once the CRP level is more than 50 milligrams per liter or more than 5 milligrams per deciliter, these patients are at high risk of getting severe disease. Okay, and if your lymphocyte counts keeps dropping, they drop to less than 1 and they continue to drop, these patients are at high risk of progressing onto severe disease. If your chest x-ray wasn't so bad before, now it's getting bad, or now you're getting multi-lobar involvement when earlier it was just small patches, these patients are probably turning bad as well. So once patients are in category 4, what we have learned is that they need to be completely rest in bed. That means no walking to the toilet. We give them urinals. If the patient has got diarrhea, we try to lessen the diarrhea so that they don't have to walk to the toilet more often. If they have to go to the toilet, they need portable oxygen, because we found that patients, when they are exerted, then they actually do badly. What do we do before we go into the isolation area, close to the patient? We look at the vital charts, we check the day of illness, we look at the Muse chart, and then if it's necessary to talk to the patient, it is better to actually phone them and get information before we even see the patient, so that we know that once we go in, it's a targeted reason why we are going in. Okay, so we are going in not just to go and get history. Most of the history can be gotten before you go in. Once inside, we check the input output. We check for hypoxia, as I told you earlier, exertional dyspnea, respiratory rate for 1 minute, and SpO2 levels. So the third emphasis that we want to give is, how do you protect yourselves as healthcare workers if you're working in the COVID wards? Okay, so it's checking everybody's temperature. So if you have a temperature, you should get yourself checked. Okay, don't. I know that there's a lot of emphasis on keeping to protocols and all that. So much so that I know that some healthcare workers are scared to go for testing. They think that, hey, if I test and then I'm positive, then they're going to blame me. Okay, it's not like that. All right. We know that you are working in an occupational hazard. You've got a risk of contracting COVID. If you get any symptoms, respiratory symptoms or temperature, please get yourself checked. Okay, because if not, then you'll be putting your family at risk. You'll be putting the whole team at risk. Okay, there's no penalty for contracting COVID. All right, we frown upon it if you don't take precautions. If you don't socially distance yourself from your colleagues, you go out in big groups, or you don't wear your mask, or you don't do hand hygiene. That one we frown upon. Okay, but we don't frown upon repeated testing. We don't frown upon the if you actually get COVID. Okay, we will take good care of you. We can assure that any healthcare worker who contracts COVID, the best care will be given lah. Okay, yeah. So you are essential in preventing the cycle of disease. If you are unwell, please stay at home and get yourself checked lah. Okay, yeah. So here, social distancing, keep 6 feet away from others, avoid mass gatherings, and avoid hanging out together. All right. If you have to go into the ward or the cubicle where there are COVID patients, the psychological preparation is very important. Be ready, be mindful, be careful, be vigilant. Okay, and I won't discuss much about the PPEs, but if you if you are new to PPEs or haven't been trained for PPEs or forgot about PPEs, please arrange for refresher training for PPEs. How do you don the PPEs? What kind of PPEs do you need to wear for the different levels of patients? Okay, and fit testing N95s if you need to wear an N95. Okay, so what we have here is a PPE for a credentialing process. Okay, once you have gone through the PPE training, then you are credentialed, and then once you finish your Muse training, Muse training, and then you're also credentialed. So the rules that we have for healthcare workers, if you're going into the room, go in pairs, or if you have to go in alone, there's one more person who is observing what you do so that they can remind you, or so that they can, if you need help, they can, can I need another FBC bottle, or I need, a stethoscope, somebody is there to help take it for you. Okay, know your zones. Within the wards, we've got red zones, yellow zones, and green zones. Green zones means you don't have to wear your PPEs. You can take your breaks there. You can remove your mask to take your meals. Okay. Yellow zones means it is actually a red zone, but we try to keep it as clean as possible um, by repeated cleaning lah. Okay, yeah. And then red zones, of course, are areas where potentially the virus is on all the surfaces and in the air that you breathe. Okay, regular hand hygiene. Do not touch your face and your eyes. So there are posters to remind you not to do that until you have sanitized your hands. Okay, so I'm not saying you can't touch your face or your eyes. You can, but before you do that, you have to sanitize your hands because potentially your hands are infected. All right. Watch the healthcare worker when they don the PPEs, when they take off the PPEs, especially when they take off, and remind the patient to wear a mask when the healthcare worker is entering the room. Okay, because if the patient is wearing the mask and you are wearing a mask, you're wearing a surgical mask, then the chances of you getting COVID are really, really, really minimal. Okay, or in fact, are not, they don't exist. Okay, so the patient has to wear the mask, and then you wear your mask properly as well. Now, what we have found is that much more healthcare workers actually, if they do get COVID, they get it outside the COVID wards. That means not while they're taking care of COVID patients, not while they are in charge of the COVID ward. Okay, 53% infected from other healthcare workers, 22% infected from going out to activities in the community, whether it's going for weddings, going for um, worshipping together, okay? And then 17% got infected from patients who to have COVID. Okay, there were safety patients, some other COVID. Okay, and virtually nobody got COVID by taking care of patients in the COVID ward. So especially so if some of you are there in Sabah, and there's so much in the east coast of Sabah, and so much COVID is spreading around. Really speaking, truthfully speaking, the safest place you can be is in a COVID ward, because in a COVID ward is when you are wearing all your PPEs. Okay, you're taking all the precautions. That's the time when you are the safest. Okay, yeah. But it's when you go out to the community and you forget to social distance, or you forget to wear your mask, that's when the risk are the highest for you kena COVID lah. Okay, yeah. So this is our famous KKM poster: avoid crowded places, avoid confined spaces, especially indoor spaces lah. If you have to go outdoors, if you have to go outdoors rather than into an air-conditioned area. All right, this is our meetings in the Sungai Buloh at the height of COVID. Everybody was wearing a mask and socially distancing. We still use our auditoriums. We try to keep the events as short as possible. Everybody wears masks, seats away from each other. This is another meeting space. and when it's time for the pantry, sorry, we only allow 2 people in a pantry at any time, and that also you sit far from each other. Pantries are at higher risk because that's where you remove your mask to eat. Yeah. So the best way to avoid spreading COVID and to avoid getting infected by COVID is to assume you are already infected. So if you're already infected, you don't go near people and you wear your mask all the time. Okay, yeah, and by doing that, you're actually helping yourself and you're helping others. And the last is main priority is to conserve PPEs. I won't be mentioning much about what type of PPEs you need to wear because you have your own local guidelines where you are. But what we do want to say is that if you are taking care of people with PUIs, okay, patients under investigation, you need your face shield, you need the gloves, you need gown, you need head cover together with your mask, of course, yeah. All right, when you are entering the room. But when you move from one patient to another, actually you don't have to change your N95 mask or your face mask or your eye shield. Okay, all you need to change is the outer gown, okay, and the outer gloves lah. Okay, and change the gown and change the outer gloves. Okay, and of course, if there's any PPEs, if your mask happen to be soiled, if your eye shield happen to be soiled, then you should change it and practice hand hygiene between patients. If for confirmed patients, if you are in charge of a cubicle that is cohorts, confirmed cases, it's even easier. Okay, you wear face shields, gowns, gloves, head cover, and a mask, and you actually only change your gloves between patients. And of course, if your gown is soiled, then you change it. If your mask is soiled, you change it. But otherwise, you maintain everything else, just hand hygiene between patients. Okay. All right. So when we try to go in as short time a period and try to do as many things that needs to be done, give medicines, take observations, examine the patient, all within the same visit, so the same person may have to do all of this. Okay, so it's not only, so we control our entries, so it is not nurses going in, coming out, and then another nurse goes in to take observation, and then another doctor goes in to check the patient, another goes in to go and take the history. It's not like that. Okay, it's a pair of 2 people go in, give the medicines, if necessary, give the diet, take the observations, examine the patient, and then go out there and don't have to come in there if the patient is not ill anymore. Okay, yeah. Reviews. So sometimes the patients are very young and they are category 1, and we can actually use the phone reviews and talk to the patients, how are you feeling and all that. Okay, that will limit the number of times you need to go in there. Okay. These are slides on how do you manage a patient with COVID. I won't spend too much time on this, but I just want to emphasize that COVID is a disease of phases. In the first phase, it is a viral disease. Okay, the first 1 week, it is a viral. The virus is the one that's making the person ill. In the second week of the disease, what happens is that the immune system is the one that some patients get an exaggerated immune response. And when they get an exaggerated immune response, as you can see here, inflammatory response goes up. Second week, the virus is actually coming down already, but the inflammatory response goes up. And when that happens for some people, the inflammatory response is so great that it causes damage to the lungs. Okay, so the treatment is basically first week, give them antivirals if they are at high risk of getting severe disease or warning signs of virals. By the time we get to the second week, if there's signs that the inflammatory response is going up, then we give anti-inflammatories like steroids. Okay, yeah. So I mentioned the first 1 week is usually a viral disease. Second 1 week is inflammatory disease. How do we know that the inflammation is going out of hand? If the patient has got persistent fever, his oxygen requirements are increasing, his CRP levels, what we find is that the CRP levels is a good marker that the immune system is going crazy, because in viral disease itself, the CRP doesn't go up. Right? Continues to drop, And if you have this test called interleukin levels, interleukin 6 levels, then you can show very high levels as well. But we found that it correlates very well with CRP. So most of us won't have IL-6 levels. We use CRP levels to know whether the inflammation is going out of hand. Okay, and if it is going out of hand, then we use steroids. All right. This is another type of anti-inflammatory tocilizumab. Until now, I don't know how to pronounce it properly. There's a role for it as well, but you don't need to know it. Category 1 to 3, generally we don't give any category 1 we don't treat. Category 2, if the patient has got warning signs, then we treat as category 4. Okay, that means we have to prepare our steroids already. Okay, if the patient is category 3, if there are warning signs present, then we treat as category 4. Or if the patient is more than 50 years old, has got end-stage renal failure, then we also treat as category 4. All right. Category 4 is basically giving the antivirals, which is the favipiravir and the interferons. Okay, yeah. This is the antivirals, and the other medicines that we give also is the prophylaxis against DVTs and pulmonary embolism. So you can use prophylaxis, okay, for all patients in category 4. All right. This is once you have confirmed PE, then you use these doses. There's also one dose in the middle. Okay. These are based when the patient is 5 dose of prophylaxis. Okay. There's some slides on infectivity and discharge. We know that I mentioned the peak viral load is around the time when the symptoms start. Okay, and majority of secondary infections occur. That means you spread COVID to another person usually before day 5 of your illness. All right. After day 5, the viral loads in your body are actually quite low. Once they are quite low, the chances of you spreading is actually much less. Okay. And they have found that beyond 10 days, they can't even culture the virus anymore. That means the virus is so little that it can't be cultured after day 10. These are in mild to moderate patients, category 1, 2, 3. But category 4 and 5, the virus can remain very active even until day 15. Okay, but by day 15, then it's less than 5% probability of being able to culture the virus. And from literature, we know that up to by the time reach day 20, hardly anybody sheds out live virus anymore. Okay, but your PCR throughout this period can remain positive. Okay, and even up to 90 days, the PCR can still remain positive, but it's actually all effectively what we conveniently term as dead virus. All right. Discharge criteria is if the patient is symptomatic, then the patient needs to be asymptomatic, or the symptoms all dramatic have improved. At least 72 hours, all the symptoms have gotten better. Okay, or at least 14 days since the symptoms first appeared. Okay, so earlier I told you if I'm exposed today, my symptoms will probably start on Friday. It's 14 days after Friday. That means not this Friday when my symptoms start. 2 Fridays after that, then I can consider discharging the patient. If the patient is asymptomatic, absolutely no symptoms, I didn't even know I got COVID until you tested me, then how do I know when my symptoms started? You won't know. So we take 14 days after the first positive COVID result. Okay, yeah. So this so if the patient is so ill that needed to go to ICU or nasal prong, by day 14 we could take up the oxygen. By day 18 the patient is feeling better. Respiratory symptoms have recovering, comorbids all controlled. 72 hours after that they are fit for discharge. In mild patients, the symptoms start about let's say they start about day 5. By day 8 the symptoms have resolved. By day 14 you can actually discharge the patient because his symptoms sorry, this is 5 days of symptoms and they already had 5 days of symptoms. So they were admitted at day 5. Okay, they have 5 days of symptoms. They were admitted at day 5. You don't have to wait for 14 days of admission. You wait for 14 days of since symptoms started. This is for mild disease. All right. admission during the pre-symptoms. So sometimes you get patients who are admitted because from contact tracing, so they come into the ward at day 0, okay, no symptoms at all. And then next day the symptoms start. When can you discharge them? 14 days after the symptoms start. So that means it's not 14 days after admission, it's 14 days after the symptoms start. So for this patient, it's day 15 of the illness. Okay, and for those with uncontrolled comorbidities, let's say they need to be in hospital for some other reason, because they've got a stroke, or because they've got whatever other disease, a fractured leg or something like that. Okay, so in this case, it was presented with a CVA. Okay, mild pneumonia, never needed oxygen. After 14 days, you can take him out of the respiratory of the COVID ward and put him in whatever ward that he actually needs to be in, because he's, whether they are pregnant or whether they need to go for rehab and all that. Okay. Right, then just some reminders for patients in the ward: always wear your mask when the staff comes in. Don't go near each other, because we have to cohort many of these patients. We sometimes even PUIs, we try not to cohort them, but sometimes we're short of beds, we cohort them. We tell them, don't go near each other, wash your hands all the time, stay away from each other, don't go and sit on each other's bed So there's orientation packages for the patients, welcome messaging, housekeeping rules. Okay, what do we tell them? This is our hospital, Sungai Buloh handout. So we give all of this to the patient, so that because if you don't give all of this, it's almost like being in a hotel. You've got a note there on your bed there, tell you, what time it's open for buffet breakfast, that kind of thing. So that use the entire information. For communication, whether they want to update the family members themselves, or would they like us to update them. If they like us to update them, please give your if the patient is unstable, of course, we need to contact them. Right, this is remember about confidentiality. Please, we use a lot of WhatsApp in a time of COVID, but you are not allowed to give information to your family members, to your neighborhood group, or whatever group you are in. Okay, so everything is confidential. Be careful if you are sending something by WhatsApp. Either send it to somebody whom you really trust, or wipe out all the identifying data. Okay, yeah, and don't put it in social media. Please don't put it in social media. All right, that's all I have. Thank you. Any questions?